So good evening, everyone, and welcome to this week's tutorial with Toby. And our topic is a very, very common and familiar topic in anesthesia. And we're just going to remind ourselves and have some discussion on this topic, inhalational anesthetic agents. So that's our topic. And linear comes at the end of this tutorial. Every one of you should be able to understand the mechanism of actions of inhalation anesthetics, should be able to compare the properties of common inhalation agents, be able to evaluate their clinical applications and safety considerations. And hopefully we should be able to look at modern anesthesia techniques, especially bordering on low flow anesthesia. So we're going to follow this outline. So, by way of introduction, inhalation anesthetic agents are either gases or volatile liquids which are administered via the patient's airway to produce anesthetic effect. They are commonly used for induction and maintenance of anesthesia, and very recently, should I say, has been incorporated into the ICU to serve for continuous sedation. They are broadly classified as halogenated hydrocarbons, such as halothane and trichloroethylene, and halogenated ethers, such as the other ones, the diethyl ether, enfluorine, isoflurane, and the likes. So history, just remind ourselves, remember the World Anesthesia Day, all right, in honor of William Moulton, who demonstrated ether as an anesthetic agent at Massachusetts General Hospital in 1846. Earlier agents such as diethyl chloroform, ethyl chloride, cyclopropane, and trichloroethylene, although were very effective anesthetic agents, but their use have been discontinued either because they are highly flammable or because of their high toxicity profile. Halothane, the only halogenated hydrocarbon still used in some parts of the world, was discovered in 1951 and was first clinically used in 1956. And it was found to have more favorable safety profile, all right, and marked the era of volatile hydrocarbons and fluorinated ethers in anesthesia. All right, so in terms of chronology, you see this on the right side. All right, as with all agents, we're always looking for the ideal agent. All right, and you and I know that none is in existence, but we'll keep trying to, look for the ideal volatile agent, and the property is Pan-African. So an ideal volatile agent should be Pan-African. All right, P must be potent in small concentration. It must have both anesthetic and analgesic effect. It must be not depressive to the cardiovascular and respiratory system. It must be affordable and cheap. One of the things that is still going for halothane in some areas. It must have rapid and smooth induction and recovery from anesthesia. It must be compatible with catecholamines like your epinephrine and norepinephrine. It must be non-flammable and non-explosive. It should be non-toxic with little or no biotransformation. So if we're looking for an ideal volatile agent, let's look for those that fulfill these characteristics that has been Pan-African. All right, so the mechanism of action, there's been theories over the years to try to elucidate the mechanism of action of volatile agent. All right, and the first one was as a result of a discovery by Lee and Overton, when they found out that there existed a linear relationship between MHC and lipid solubility. Right? So this led them to theorize that volatile anesthetic agent cause interruption of the usual function of the cell membrane lipid bilayer by penetrating and disrupting the molecular arrangement of phospholipids and ion channels. All right? This was the theory that was proposed. We know as the lipid theory or the Meyer-Overton correlation. But recently, or rather, this theory has been superseded by what we know as the protein theory. All right, and this relies on the increasing evidence that anesthetic agents exert their effect by two ways. They inhibit the excitatory NMDA receptors while activating inhibitory GABA alpha subunit receptors. All right. So it was now discovered that the relationship between lipid solubility and potency, all right, can be explained by the lipophilic nature of the specific protein binding sites on the ion channels. All right. There's what we call the unitary theory, which tries to put the two together. But suffice to know that these two theories do have their basis, but we now know that volatile anesthetic agents actually act by activating the inhibitory pathway of the GABA alpha receptors and the glycine ion channels. And these are distributed throughout the CNS. And that's how they exert their anesthetic effect. So inhalational anesthetics are classified based on different criteria. Number one, based on their volatility. All right. So volatile agents are actually liquids that need to turn to vapor before they administer to the biovaporizer. So volatile agents such as halothane, isoflurane, and sevoflurane are liquids in their natural state, but need to be vaporized before they can be administered. Then we have those that exist in gaseous exchange in gaseous state at room temperature. All right, the nitrous oxide, and the xenon gas. Okay, inhalation anesthetics may also be classified on the basis of their chemical structures. The hydrocarbons, all right, we have the halogenated hydrocarbons, and we have the inorganic gases, the inert gases, or known as the noble gases. Okay, so there are factors that affect the actions of volatile agents, all right? The MSUV, the MSUV. The M there refers to the minimum alveolar concentration, which is defined as the minimum concentration of a volatile agent in the alveoli, which produces immobility in 50% of patients following surgical stimulation. All right, so the lower the MS of an agent, the more potent the agent is. So if we look at the MSC of halothane compared with that of nitrous oxide, the MSC of halothane is 0.75, while that of nitrous oxide is about 105. So from here, we can see that halothane is more potent than nitrous oxide. The second factor that affects the action of volatile agent is the solubility of the agent. So at the solubility, especially solubility in blood, we have solubility in oil or lipid solubility. But we're talking about solubility in blood, which is expressed as the blood gas partition coefficient. So the lower the solubility of an agent, the faster the onset. All right. And this is because it readily, all right, can get to the brain to exert its action. While higher solubility will have slower onset. For instance, halothane. Then the volatility of the agent itself, all right? This talks about the ability, the readiness with which the agent volatiles or can readily be turned into a vapor, which is affected by both the temperature of the agent and the saturated vapor pressure. So the more volatile an agent is, the more rapid, all right, induction of anesthesia, more rapid and smooth will be the induction of anesthesia. So desflurane, for instance, has the highest vapor pressure and the lowest boiling point, which makes it highly volatile. And that is why they can induce, it has a very, in fact, they use the word ultra short duration of induction, ultra short, rapid, and smooth induction. But that property also has its own limitations, as we will see as we proceed. Sevoflurane has a lower vapor pressure than desflurane, and thus is less volatile. Why isoflurane and halogen have intermediate volatility. So the last factor is the uptake. All right, we're talking about how the agent is taken up by the brain, where it produces its anesthetic effect. And this is dependent on the cardiac output, the inspired concentration of the agent, and the patient's alveolar ventilation. So a higher cardiac output will lead to a slower induction because the agent will be rapidly taken away from the alveoli. Conversely, induction of anesthesia is faster in low cardiac output state, like in shock. All right, and that's why when it's not advisable to do induction of anesthesia in patient in shock. All right, because the induction will be faster and it can have cardiovascular collapse. The inspired concentration of the agent. So the higher the inspired concentration, obviously the more rapid alveolar concentration and uptake by the brain. All right, patients with greater alveolar ventilation, like in pediatric group, especially infants, they will have more rapid induction of anesthesia. So we remind ourselves that the common factors that affect the actions of volatile agent is MSUV, the MAC, the solubility in blood, the uptake of the agent by the brain, and the volatility of the agent itself. So let's talk about let's dig a little into MAC, all right? We have four different types. We have the standard MAC, which is the MAC 50, all right? And is described as the alveolar concentration of the agent that's required to prevent movement in 50% of patients that are exposed to surgical stimulation. Know that this is the primary index of anesthetic potency. So the lower the MSC, the higher the potency of the agent. We have the MSC 95. All right, this is the alveolar concentration that is needed to prevent movement in 95% of patients after surgical stimulation. Typically, it's about 1.2 to 1.3 times the MAC 50 value. Then we have the MAC awake. This is the alveolar concentration at which 50% of patients will regain consciousness. All right. And usually it's about 0.3 to 0.5 times the MAC 50. And it's an important index for emergence from anesthesia. How quickly will a patient emerge from anesthesia is dependent on what we know as the MAC awake. Then we have the MAC bar, all right? This is the alveolar concentration that is required to prevent autonomic responses for surgical stimulation, such as tachycardia or hypotension. Usually, this will require about 1.5 times the MAC 50. All right, so there are factors that either decrease or increase MAC. So patients who are elderly, hypothermia, pregnancy state, patients who are hypotensive or hypoxic or hypercarbic, all right? Patients on opioid, benzodiazepine, or other anesthetic adjuvants. All right, this one will decrease the MSC requirements of the agent. All right, in some cases, MSC increases, meaning that you need an anesthetic agent. And this occurs with younger age group, infants, hyperthermia, all right, because of easy metabolism, chronic alcohol use, all right, leading to enzyme induction, hyperthyroidism. These are some of the factors that will increase MAC values. All right, I just brought this here to remind us the differences, all right, in inhalational induction between children and adults, all right? And we're looking at it from four different factors: the ventilation and F functional residual capacity ratio. Children, because they have a higher minute ventilation to FAC ratio, all right, they tend to have faster uptake of the agent, and thus they have faster onset of anesthesia. All right. Number two, children have a higher risk of laryngospasm, so potent agents such as desflurane and isoflurane should not be used. In fact, sevoflurane is the darling of pediatric anesthesiologists because it's not irritant. All right. And those days, those of us that use halothane, halothane was what we were using. Halothane was beautiful, had a very beautiful smell, and it was not irritant. All right. In very low resource environment where sevoflurane may not be available. All right. I don't know how many of us have sevoflurane in our centers. We still use halothane for induction of anesthesia in pediatric age group. All right, the factor of metabolic demand. All right, children have a higher metabolic rate and therefore require higher MAC. All right, so they require higher concentration of inhaled anesthetics to induce onset of induction of anesthesia. All right. In terms of cardiac output dependence in children, their cardiac output is heart rate dependent. All right. And inhalation agent can actually reduce stroke volume without compensatory vasodilatation. So this will lead to bradycardia. All right. Another thing is that because they have higher cardiac output, all right, they tend to have slower induction of anesthesia, coupled with the fact that they have resultant bradycardia due to the effect of the inhalation agents on the stroke volume. Okay, so generally, that is about the general description of inhalational agents. So we're going to go into the specific agent. We're going to concentrate on the unique things about each of the agents. So before we continue, I have these case-based MCQs for you. I hope you can see the question. A 5-year-old child undergoing a tonsillectomy. Please mute your mic. Okay, let's look at the question, people. Anybody want to take a go at it? A 5-year-old child undergoing a tonsillectomy under GA with halothane suddenly develops ventricular extrasystoles, which progresses to ventricular tachycardia shortly after the surgeon injects epinephrine at a dilution of 1 to 100,000 for local vasoconstriction. So what is the most likely cause of this arrhythmia? Anyone?
So I think it's B, catecholamine-induced myocardial sensitization.
All right. Do we agree? You're right. All right. So don't let us
Yes, sir.
debate that. Okay. Number two, a 3-year-old child is undergoing an elective hernia repair under halothane anesthesia. Midway through the surgery, the patient develops sudden tachycardia. Heart rate jumped up to 180 beats per minute, and he has frequent PVCs. all right, premature ventricular contractions. Although the patient remains hemodynamically stable, what will be your first line management in this patient? Anyone? Anybody?
I think, Prof, is A, sir. Stop the allotene and administer 100% oxygen, sir.
All right, all right, all right. Okay, no time to waste. A 7-year-old child under allotene anesthesia developed ventricular tachycardia with a pulse after receiving a high dose of epinephrine. The patient has developed hypotension and poor perfusion. So what is the most appropriate immediate intervention here? Anyone? Anyone? My people are quiet.
Hey, Prof. Defibrillation at 2, because the patient is unstable.
Yeah, the patient is unstable. Okay. Any other one? Any other answer different from that?
Synchronized cardioversion.
Synchronized cardioversion. Okay. Any other answer?
IV lidocaine 1 milligram per kg.
Okay, we don't have time. I would have said you should defend your answer. Maybe we'll come back to that later on. All right.
What of a beta blocker, sir?
No, this patient has the catch here is don't forget that this is VT. Okay, so the answer is between defibrillation and synchronized cardioversion. Okay, because the patient, has hypotension and has poor perfusion. So you're not going to use lidocaine and metoprolol here. All right. So the
Yeah.
answer is between A and C.
It's C, sir.
It's C, because patient is unstable with tachyarrhythmia.
Yeah. The person that mentioned C, you have a point. Anybody who mentioned C, you want to talk about it?
Yeah, so see, this patient has features of instability. There's hypotension and the poor perfusion. So that's an unstable tachyarrhythmia,
Yeah, but,
which
but defibrillation we have, and don't forget that the patient is under anesthesia.
Yes, but it's the VT is with the pulse. The fibrillation will help with pulseless VT.
Yeah, the patient has a pulse. Okay. All right, let's go to the next question because of time. The patient has a pulse, correct observation. Let's look at it. We'll come back to that. A 10-year-old undergoing an adenotoxectomy under hallucinating anesthesia develops recurrent premature ventricular contractions and non-sustained ventricular tachycardia. The ECG shows a prolonged QT interval. So which of the following electrolyte imbalance is most likely to worsen this condition? This is a giveaway, isn't it? Quickly, what's the answer?
B.
Yeah. Do we all agree?
Yes, B.
Yes.
Okay, great. Please, can you mute your mic? Please let me tell our people to mute their mic when they come in. Okay, where am I? Is this another question? Oh, time is
Yes, sir.
going. This is another question. Did I press
Yes,
on?
sir.
Okay, so look at the answers. We'll come back to it if you have the slide. These are the answers I've provided. Okay. So the what changed the dynamics of question number 3 is because the patient has a pulse. It was there. So cardioversion will be the best treatment. So let's look at halotene. How many of you still have halotene in your centers? Can I get a chorus answer? Do you still use halothane?
Yes.
Yes, we do.
Okay,
Yes.
okay. All right, so halothane is the only halogenated hydrocarbon still in use. All right, it's a colorless liquid with a sweet smell at room temperature and pressure. It is stored in amber colored bottle. Why? With thermal to enhance stability. All right, if it is exposed to sunlight, it becomes unstable. All right, in so many places, halothane has faced that because of concerns about halothane hepatitis and its cardiovascular effect, although it still remains in use in so many low resource settings due to its affordability. And don't forget that we did say some of the ideal purposes of, excuse me, some of the properties of an ideal anesthetic is that it should be affordable. All right, like we said, it enhances the GABA A receptor activity while depressing or inhibiting the NMDA receptors. All right. So, MC questions, those days, I don't know if they still ask. I remember when I was writing primaries those days, they can ask you what is the chemical formula of halothane. So it's 2-bromo, 2-chloro, 1,1,1 trifluoroethane. This is the formula here. All right, that's a blood gas coefficient of 2.5, oil gas coefficient of 2.25. So it's more lipid soluble than blood soluble. Okay. The MAC is about 0.75%, boiling point of 50, and it has a saturated vapor pressure of 243 millimeters of mercury at 20 degrees Celsius. All right. Okay, so many good things about halothane. It's a bronchodilator, so it is very useful for patients with asthma or other obstructive airway disease, and it inhibits the production of secretions. So that makes it very good. All right, although it can cause respiratory depression in high concentration. It produces vasodilatation with a dose-dependent reduction in blood pressure. All right, and those days when we're doing anesthesia as residents, all right, we're aware of this, that it sensitizes the heart to catecholamine, predisposing the patient to arrhythmia. So what we used to do, especially those surgeons that want to infiltrate with local anesthetic agent, please be on top of your game. Ask what concentration are you using. All right. So we want to save the heart from going into arrhythmia. So the safe one, how many of you knows the safe dilution that we allow for adrenaline during halothane anesthesia? Anybody? What do you allow in your center? Have you seen surgeons diluting adrenaline for infiltration or for local vasoconstriction during halothane anesthesia? Those of you that still use halothane,
One
or
in
you do not
100,000.
Yes,
care?
sir.
One in
No, sir.
100,000.
Yes, sir.
So what is
We use
what?
one in 100,000. One in 100,000.
Wow, you are
We
you are
advertise
brave.
one
You
in
allow one in
Let's
100,000. How many of you allow one in 100,000?
yes. So
less than 1 in
the more they dilute,
200,000.
so some can dilute further to 1 in
Those
200,000,
days,
but mostly
mostly what? Mostly what? Mostly 1 in 100 or 1 in 200?
mostly 1 in 100,000. They could dilute further to 1 in 200,000, sir. And 1 in 100,000. They can do further dilution to 1 in 200,000.
The textbook says 10 mils of 1 in 100,000. That's what the textbook says.
Yeah, a lot of time those days in fact, especially for those that want to give high volumes, we insist on 1 in 200. I don't know if you guys allow 1-800. Those days, maybe it has changed. I remember Professor Kolawole and Professor Bolaji in Ilorin. They will breathe on our neck, 1 in 200,000. All right, those of us that trained in Ilorin during my time, it was 1 in 200,000. All right. So, general system, don't forget the relationship between halothane and PPH, all right, because it causes uterine relaxation. All right, it produces cerebral vasodilatation with an increase in ICP, all right, and that's why the use of halothane during neurosurgical procedure should be done with precaution. All right, enhances and potentiates the action of neuromuscular blockers, and is metabolized in the liver, all right, to about 20%. And the metabolites are active and they can cause hepatitis. All right, the incidence of hallucinogenic hepatitis is very rare, but increases in patients who are exposed to multiple halogen anesthesia within a short interval. If I remember an incident, Professor Kolawole from Ilorin, I remember an incident, we were doing a case together, and I think we had induced, in fact, we started anesthesia. I think the surgeon either changed his mind or something. And I remember my boss was furious. He said, no, 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 if we don't do the case now, I'm not going to do the case tomorrow. I think the surgeon wanted to do the case tomorrow or something. And the issue is that I'm not going to expose this patient to multiple allotted anesthesia within a short interval. All right. So the incidence also increases in middle-aged obese women. Don't forget, because of the lipid solubility, I did tell you that halothane has a higher lipid solubility. What's it called? The oil gas coefficient is higher. All right. So based on family history of halothane toxicity, all right, and that's why it's very important for us to do a pre-anesthetic review to ask if anybody in your family has had general anesthesia under halothane. Okay, so the disadvantages and adverse effects, halothane and hepatitis, which is an immune-mediated hepatic necrosis, can be fatal. All right, like we said, it's more common after multiple exposure within a short period of time. So it's contraindicated in patients with halothane exposure. All right, that's to do with time, also duration. All right, predisposes to cardiac arrhythmias by sensitizing the heart to catecholamine with risk of ventricular arrhythmias, like we saw in our case-based MCQ. So you want to avoid halothane patient with pheochromocytoma or patient with severe cardiac disease because of the risk of arrhythmias. It causes dose-dependent hypotension. All right, you don't want to use it for shock, in shock state or low cardiac output state. All right, and in high doses can actually cause hypoventilation requiring ventilatory support. One other very strong adverse effect is malignant hypothermia. Halothane can trigger malignant hypothermia, all right, which is a genetic predisposition to uncontrolled calcium release from the sarcoplasmic reticulum, leading to hypothermia, muscle rigidity, hypercarbia, acidosis, and all. Okay, this is just the follow-up on malignant hypothermia. So contraindications or caution to halothane. All right, these are things should be on our fingertip. All right, so I try to make it a mnemonic. Halothane will cause contraindication to halothane. So hypovolemia, arrhythmias, liver dysfunction, obstetrics patient. All right, I hope I'm right. Do we still do halothane for obstetric patient? All right, tumor, especially due to risk of raised ICP, patient with hemochromatocytoma, patient with aortic stenosis, all right, aortic or mitral stenosis, those fixed cardiac output state because of the dose-dependent reduction in blood pressure, and patients who you're going to use epinephrine. So instead of fighting with the surgeons, make it 1 in 200, make it 1 in 100, some surgeons can be very stubborn. Say, no, 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 I'm not going to get my desired vasoconstriction I need here. I want to use 1 in 10,000. You don't want to use Haloten for such patient. So in summary, Haloten is a potent but now becoming outdated volatile anesthetic agent. It's non-irritant, smooth induction, and has bronchodilator properties. Sweet Haloten. Serious side effects do occur: Haloten hepatitis, cardiac depression, arrhythmias, the risk of malignant hypothermia. Although in most advanced settings, rarely used, but we still find it in our settings, resource limited settings. All right. Okay, so if you see this question, all right, a 6-year-old child is scheduled for an elective tonsillectomy under GA. The anesthetist decides to use Haloten for inhalational induction due to its non-irritant properties, correct? However, during the procedure, the child suddenly develops tachycardia and irregular ventricular beats shortly after the surgeon administered epinephrine at the dilution of 1 in 100,000. The ECG reveals ventricular extrasystoles progressing to ventricular tachycardia. So, what are your differentials? We've mentioned this before.
Is he only one? If you bring it, keep it on that chair.
My people, Mona, don't let me speak pidgin English now. Let's please mute our mics. This session is being recorded. So what are your differentials? This can come out in the short answer questions. Give reasons for your answer and describe your management. I'm sure all of us will be comfortable to answer this question. True or false?
Yes, sir.
All right. Only one person is comfortable to answer the question. Will be good to answer this question.
Yes, sir.
Okay, great. Great. Okay, so let's do isoflurane now. So isoflurane, most centers those days, we have two. We have, isoflurane and Haloten vaporizers in our old anesthetic machine. So we're all familiar with isoflurane. It's a halogenated methyl ether, colorless with a pungent smell, all right, which differentiates it from Haloten. But the good thing that it's stable, unlike Haloten, and it's compatible with soda lime. Okay, this is the chemical formula: 1-chloro, 2,2,2 trifluoroethyl difluoromethyl ether. All right, blood gas coefficient is 1.4. Oil gas coefficient is 97. MAC is higher than that of Haloten, 1.15%. All right, and boiling point is 49, and has similar saturated vapor pressure with Haloten, 250 millimeters of mercury. All right, so isoflurane has a more depressant effect than Haloten. All right, also produces bronchodilation, but its irritant effect on the airway can lead to coughing and laryngospasm. So you don't want to use it for induction in children. You don't want to use it for maintenance in patients with reactive airways. All right. The significant thing about the CVS effect is that isoflurane can induce what is known as coronary still syndrome. All right, because it causes vasodilatation. All right, for patients with what's it called? Constrictive artery disease, patient with ischemic heart disease. All right, their blood vessels may not respond to the vasodilatation effect of isoflurane. So blood is stolen, let's use that word, from those ischemic regions of the heart to the more perfused. So it's known as coronary artery syndrome. So and this is one of the reasons why it is contraindicated in patient with ischemic heart disease or coronary artery disease. All right, isoflurane increases cerebral blood flow and increases intracranial pressure. So you don't want to, it's not a friend of neurosurgeons. All right. And it causes muscle relaxation, okay, and potentially the effect of muscle relaxant may also precipitate MH, malignant hypothermia. Unlike halothane, it's only about 0.2% of it that is metabolized in the liver. All right, unlike halothane that has up to 20% metabolism in the liver. All right, and the remaining of isoflurane is excreted in the lungs. Okay, so contraindications, history of malignant hypothermia, you don't want to be used in severe shock or severe hypotension shock, and obviously not a candidate for inhalational induction in children. So use with caution in patients with intracranial hypertension, avoid the patient with coronary artery disease due to the coronary still risk, and also requires adequate ventilation to prevent carbon dioxide retention. So in summary, isoflurane is a widely used inhalation agent with moderate solubility, low metabolism, 0.2%, and has some degree of hemodynamic stability. It is not ideal for inhalational induction due to airway irritation, all right? Although precise cardiac better than halothane may cause coronary still syndrome in ischemic portions of the myocardium. All right, it has minimal hepatic metabolism, making it safer for the liver than halothane. All right, and I'm questioning this. All right, sometimes because it requires, it has some stability. All right, it may be used in neurosurgery, cardiac surgery, and patients who require vasodilation, especially for maintenance and not for induction. Okay, quickly. Case-based MCQs for isoflurane. A 65-year-old patient with a history of coronary artery disease is undergoing laparoscopic surgery under GA. Which of the following inhalational agents should be used with caution? I'll stop there. In fact, I've given the question away. So what's the answer?
Isoflurane.
Isoflurane, all right? If I'm going to set this question, I will remove that coronary C syndrome so that I'll trick you a little. Isoflurane, correct. Which of the following is an advantage of isoflurane over halothane? A, faster induction time, lower MAC, reduced myocardial depression, high hepatic metabolism. So which of the following is an advantage of isoflurane over halothane? Anyone?
My option C.
C, correct. Correct. All right, reduced myocardial depression. Okay, all right. Sevoflurane, let's run. We have a few minutes and we have 70 something, 81 slides. Oh my God, where am I? You know, my plan always for you guys, because it's postgraduate, I want to give you as much information as possible so that even if you don't read any textbook again, the slide is enough for you for life. All right. So that's why my slides look very voluminous. I hope you like it like that. All right.
Yes, sir. We really like it. Yes, sir.
Okay. So sevoflurane is a highly fluorinated methyl isopropyl with a sweet smell. Yeah, any pediatric anesthetist there will be happy with this, okay? It has a very fast onset and offset of action used for one breath induction of anesthesia. Can somebody tell me, what do you mean by one breath induction of anesthesia? Anybody? What do you understand by that? One breath induction of anesthesia. Anybody? I'm sure you have heard about that before. Nobody? What is one breath induction time? They are sleeping under sevoflurane induction. Guys, Prince John, you want to say something or you are just joining? You are muted your mic. Nobody's answering me. Okay, you don't know then. I assume you don't know. Okay, let's go. Okay, we'll look at it as we go on. It has an excellent safety profile and has found wide use in outpatient and pediatric anesthesia. Okay, the chemical formula is 111333 hexafluoroisopropyl ether. Blood gas coefficient is 0.68, oil gas coefficient 53, MAC 2.1, boiling point 58, and the saturated vapor pressure of 157 millimeters of mercury at 20 degrees Celsius. Sevoflurane has minimal respiratory depression compared to other agents. It is not irritating to the airway, so it's ideal for inhalational induction. And it also produces bronchodilation, which is useful in asthmatic patients. Okay, may cause vasodilatation and hypotension with little or no compensatory tachycardia, reduces myocardial oxygen demand, and does not commonly cause arrhythmias, unlike halothane. Beauty of sevoflurane also is that it precedes cerebral autoregulation, reduces cerebral metabolic oxygen demand, therefore reducing both ICP and IOP. The only problem is that it may cause emergence phenomenon. All right, just like others, produces muscularization and may potentiate the effects of your neuromuscular blockers. All right, may also precipitate malignant hyperthermia. All right, the problem with metabolism is that sevoflurane may cause a formation of compound A in carbon dioxide absorbers. So, and this is potentially toxic to the liver, to the kidney. All right, but in normal flow is usually not significant. So this is one of the disadvantages of using sevoflurane for low flow anesthesia because you require adequate ventilation to prevent the formation of compound A. Contraindications, malignant hypothermia, severe hypotension or shock. You should use with caution in patient in renal impairment. All right, avoid a low flow anesthesia because it requires adequate ventilation to prevent carbon dioxide retention. So, summary, sevoflurane is a fast-acting, non-irritating volatile anesthetic preferred in pediatric anesthesia and for patients with reactive airway. All right, it has minimal cardiovascular depression, which makes it ideal for hemodynamically unstable patients. Risk of combined formation is a concern in low flow anesthesia, but rarely clinically significant. Its lower blocker stability than isoflurane leads to faster induction and recovery from anesthesia. All right, quickly, a 5-year-old child is scheduled for elective hernia repair. Which inhalation agent is preferred for induction? The answer is sevoflurane. We know that, isn't it? All right. Does anybody want to choose halothane here?
No, sir.
Why? Why not halothane? Halothane is also not irritating.
Yes, sir,
what in sevoflurane will make you choose sevoflurane over halothane?
Yeah, faster induction time, faster time for emergency.
Faster, beautiful. That's so faster. It's not just because it's not irritating, because halothane is also non-irritating. Okay, because it produces one breath induction time. All right. So which of the following is a major advantage of sevo over isoflurane? Quickly.
Isoflurane can cause breath holding, laryngospasms, which sevo will not.
So the question here is this: which of the following is a major advantage of SIVO over isoflurane?
A.
A, correct. Lower blood gas partition coefficient, and that's what leads to what? Faster induction and recovery. A 45-year-old patient with history of asthma is undergoing elective surgery. Which of the following inhalation agent is most suitable? All right. You want to choose SIVO again, isn't it?
Sevoflurane C.
Okay, I agree. A patient undergoing low flow anesthesia with SIVO is found to have elevated serum creatinine post-operatively. Which of the following is the most likely cause? Compound A formation, direct hepatotoxicity, isoflurane exposure, malignant hyperthermia. Which is it?
Compound A.
Compound A formation. All right. So I think I've done a great job today because everybody is getting the answer today, except that nobody talked about one breath anesthesia for sevoflurane. I've not forgotten. I'll come back to it. Desflurane. I think our time is almost for spent now. How many of you have desflurane in your center? Anyone? Does anybody have desflurane? Any center with desflurane? No. Okay, if nobody, let's learn about it. Okay. So desflurane is another highly fluorinated methyl ethyl agent with a very rapid onset. In fact, it's described as ultra short-acting onset and onset of action due to its low solubility in blood. However, its major drawback is low potency, urgency, and very, very expensive. All right, another important feature of desflurane is its requirement for a specialized vaporizer, which is electrically powered, heating the liquid to a constant temperature because of its low boiling point. Okay, this is the formula: 1-fluoro-2,2,2-trifluoroethyl difluoromethyl ethyl. Blood gas coefficient is 0.42. Oil gas coefficient is 19. Look at the MAC, 6. Boiling point, 23. And it has a very high saturated vapor pressure of 622. And these two last factors is what are the things that make desflurane different from the other agent. And that's what it requires a special Tech 6 desflurane vaporizer. All right, desflurane is an irritant to the airway, so it's not recommended for induction of anesthesia. All right, may produce myocardial ischemia, increases cerebral blood flow, increases intracranial pressure. All right, only by 0.02% of desflurane is metabolized, but know that it may react with soda lime to produce carbon monoxide. All right, contraindication: patient with a history of malignant hyperthermia, severe asthma or reactive airway disease. Precaution: high potency limits is used for induction. All right, requires specialized heater vaporizer due to its high volatility and may cause tachycardia at high temperature. All right, so you need requirement because desflurane has a very low boiling point. All right, so it can vaporize even at room temperature. Because of that, it can give very, how do I put it, uncontrolled, concentration. So it requires a specialized heated pressurized vaporizer. All right. Now this makes the idea is to heat the liquid to a standard temperature, a controlled temperature, thereby controlling the output of its vapor into the breathing circuit. All right. So it cannot be used, all right, in conventional vaporizer, variable vaporizer, variable bypass vaporizer. So for the Texas vaporizer, it's usually heated to 39 degrees Celsius to ensure complete vaporization, pressurized to about 1,500 millimeters of mercury to prevent unpredictable vaporization. All right, it's electrically controlled to ensure precise concentration delivery. All right. In some places where we have power or electricity problem, desflurane will be a challenge in such settings. So this is the desflurane vaporizer. If you do get the slides, you just study it, all right, the vaporizer because of our time. Advantage is it delivers accurate concentration regardless of ambient temperature and pressure because the temperature is regulated. All right. Reduces wastage due to precise control. Limitations requires electrical power, making it unsuitable for locations with unreliable electricity. All right. It's expensive compared to conventional vaporizers, and its complex design requires special maintenance. All right. So before you acquire this flame vaporizer, you need also to train your engineering department for maintenance requirements. So this is an ultra short-acting volatile anesthetic due to low blood gas solubility. It's ideal for ambulatory anesthesia and for obese patients, not suitable for inhalational induction due to its potency and airway irritation. Requires a specialized heated vaporizer due to its high volatility, minimal metabolism 0.02%, reducing hepatotoxicity concerns may cause tachycardia and hypotension at high concentrations. All right, I think we'll stop here after we do this. Hopefully, we'll send you the slides and you can read the remaining. All right, so a 50-year-old obese male undergoing laparoscopic cholecystectomy requires an anesthetic with rapid recovery. Which inhalation agent will you recommend or is most suitable? See, isn't it desflurane, isn't it? We agree on that?
Yes, sir.
Yes. Yes.
Okay. Which of the following is a major disadvantage of desflurane compared to sevoflurane? Anyone? Which of the following is a major disadvantage of desflurane compared to sevoflurane?
B.
B.
B, correct. B, correct.
Yeah, irritation.
Okay. You all passed today. That's good. Everybody passed today. Okay. Let me see where am I. Enflurane. Let's forget enflurane. We don't use enflurane. It's just for historic purposes. You can read it when you get it. Nitrous oxide is a lot. Under nitrous oxide, I think we should stop here today. Xenon, we talk about xenon. We talk about diabetes. Low flow anesthesia. I really wanted to discuss low flow anesthesia with you, but our time is gone. Okay. So really, what are the key challenges associated with low flow anesthesia and how can you mitigate them? How does low flow anesthesia impact the environmental footprint of anesthetic practice? These are part 2 questions. These are part 2 questions. I can ask this question in part 2. In which clinical scenario will low flow anesthesia be most beneficial and why? All right, ladies and gentlemen, let's stop here today.